All right, why don't we go ahead and get started, everybody? Welcome to Bioethics Grand Round, sponsored by the Center for Bioethics and Social Sciences in Medicine, or CBSSM for short. My name is Scott Roberts. I'm a faculty member in CBSSM, as well as the School of Public Health. And it's my great pleasure to introduce our speaker for today. So we're very excited to welcome Emily Largent from the University of Pennsylvania. Emily is the Emanuel and Robert Hart Assistant Professor of Medical Ethics and Health Policy at the Perelman School of Medicine there. And I'm happy to say I'm a friend and colleague of Emily's, and she really has done some fantastic work that she's going to share with you today. Emily has a really interesting background. So she has training in nursing, law, and health policy. So you don't see many folks with a JD, PhD, RN background, but Emily brings that to her work, which really focuses a lot on ethical and regulatory aspects of human subjects research. And she and I share a strong interest in ethical issues in Alzheimer's disease. And so I think she's going to talk to you today about some of her work related to biomarker disclosure in the context of Alzheimer's disease. So Emily's been recognized in many ways for her work. She's a Greenwald Faculty Scholar. She's a K awardee from the National Institute on Aging. And her work has really appeared in some high-profile journals, including New England Journal and JAMA. So Emily, it's wonderful to have you. We wish you could be here in person, but we're glad you can join us virtually. And so I will turn it over to you at this point.
Great, thank you so much. I'm delighted to be here virtually as it is. So today I will be talking a bit about biomarkers for Alzheimer's disease and some of the social and ethical implications of those biomarkers. Just by way of a disclosure at the beginning, I do have grants from the Greenwald Foundation and the National Institute on Aging, although the views I'm presenting today are entirely my own. And for the roadmap of our time together today, I'll start by talking a bit about Alzheimer's disease biomarkers. What are they, just to get everybody on the same page about what kind of information they convey. Then I'll talk about biomarkers on my mind. So what is the experience of a patient who learns that they have biomarkers? I'll talk about my biomarkers on others' minds, or what does it mean when I share this information out into the world and how do people react to me? And then at the end, I'll talk a bit about biomarkers and supported decision-making. So for that background on Alzheimer's disease biomarkers, it's important to realize that dementia is not a specific disease, but rather it's a general label for the loss of cognitive functioning, so thinking, remembering, reasoning, and also behavioral abilities to an extent that interferes with daily life. So initially, people might have trouble with instrumental activities of daily life, like paying their bills or managing their medications. But over time, they'll have trouble with basic activities of daily life, so feeding, grooming, bathing, dressing, toileting, and will typically need help from a caregiver to help with those. Now, dementia can have many causes, but Alzheimer's disease is the most common cause of dementia, accounting for about 2/3 of cases. Now, for a long time, when we think about Alzheimer's disease, it really has been understood as a clinical disorder that's defined by patterns of signs and symptoms. So an individual would present to a memory center or to their general practitioner. They would describe a characteristic onset of symptoms and challenges that they were encountering. And after conducting an exam to rule out other potential causes, particularly those that could be reversed with medication or treatment, they will be diagnosed with probable Alzheimer's disease. And that diagnosis will only be confirmed if an autopsy is performed after the patient dies. But what's really important to realize here is that in this paradigm, this clinical paradigm, you have the diagnosis of Alzheimer's disease and the diagnosis of dementia really occur simultaneously and together. But the field has started to move away from the syndromal or clinical definition of Alzheimer's disease toward a biological definition of Alzheimer's disease. And the reason for this is that recognizing that this is a tremendous public health problem, that about 5.5 million Americans have dementia, which affects not only them, but the 15.5+ million care partners who help them with those IADLs and their basic activities of daily living. Really, this is a public health crisis. And so there's been a desire to find a disease-modifying therapy that will allow us to intervene and either slow or prevent the onset of cognitive impairment. And in doing that research to find a disease-modifying therapy, there has been a great deal of work done to understand the neuropathology underlying Alzheimer's disease, which has helped us come up with this more biological definition. And so what we have now are biological markers or biomarkers that can be used to identify Alzheimer's disease pathology in vivo, so in that living brain. Now, the three that we talk about primarily in Alzheimer's disease research are amyloid, tau, and neurodegeneration. This is often known as the ATN framework, and N is provided in parentheses because it's less specific to Alzheimer's disease than amyloid and tau. And there are various ways in which we can assess biomarkers. We can do this through PET scans, we can do it through spinal taps, where we measure the biomarkers in cerebrospinal fluid, and also through MRIs. And excitingly, we also are, as a field, looking forward to the availability of blood-based biomarkers. Now, there is one test available commercially right now that will tell you about amyloid. But there's hope that this will become much more widespread and have broader availability. And blood-based biomarkers are seen as having numerous advantages over PET, CSF, and MRI, namely that they're less expensive, that they're less invasive or burdensome for individuals, and really the infrastructure is available across many settings where we can do blood tests and run these tests. And so the hope is that this will actually help both with more widespread testing and making it standard of practice that people are tested for biomarkers, but also really addressing some equity issues by making testing more accessible, not just say within the United States, but internationally. Now, one of the things that results from having these biomarkers is that we have now two distinct pieces of information. We have the individual's biomarker profile on the one hand, right? Do they have amyloid, tau, or neurodegeneration? And then we also have the syndromal cognitive staging. So people might be cognitively unimpaired. They might have mild cognitive impairment, which is more impairment than would be expected for typical age-related, cognitive decline, but not quite so much that we have that impairment of functioning that's characteristic of dementia. And so this means that we have what is now this preclinical stage of Alzheimer's disease that we can look at. So this is individuals who have Alzheimer's disease biomarkers, but are cognitively unimpaired in terms of clinical assessment. So many times these individuals do have subjective cognitive complaints, but in terms of tests of cognitive impairment that might be administered clinically, they do not measure as cognitively unimpaired, right? So these individuals are at increased risk for developing dementia caused by Alzheimer's disease. But as of now, they are cognitively unimpaired. And you can find people in the preclinical stage of Alzheimer's disease years to even a decade or more before the onset of cognitive impairment. And I really will be focusing on this preclinical stage of Alzheimer's disease today. So I will say as a caveat that preclinical Alzheimer's disease remains a research construct. This is not something that's disclosed to cognitively unimpaired adults in clinical practice. However, it's not that it's not out there in some ways. So after the June 2021 approval of aducanumab by the FDA, somewhat controversial approval of aducanumab, Biogen ended up putting together this website. It's timeweknow.com that has engaged in some direct-to-consumer marketing. You can go to this site, you can take a test to assess your cognitive concerns, and then they will recommend you to places where you can have further cognitive testing or a PET scan. And presumably these are places that would also be amenable to prescribing aducanumab to you. Now, interestingly, in their patient education materials, they do talk about preclinical Alzheimer's disease. They emphasize that you can have amyloid plaques years or even decades before the onset of symptoms. And the focus on amyloid here reflects the fact that Aduhelm is an anti-amyloid agent. So although it's not being diagnosed clinically, it is being introduced, patients are being socialized to this idea, I think with a goal of eventual off-label prescribing of aducanumab or similar agents, but that is speculation on my part. Now, if the preclinical Alzheimer's disease construct is validated and a disease-modifying therapy is found, that is one that will either slow or stop the onset of cognitive impairment, I think we can reasonably expect that biomarker testing will become standard of care. And that will be not only at, say, memory centers, but really all the way at the level of primary care, particularly if blood-based biomarker tests are available. And the overall hypothesis I have for the rest of my talk, or the argument that I'm going to be making, is that learning one's risk of dementia that will be caused by Alzheimer's disease before the onset of cognitive impairment is going to change the lived experience of millions of adults. There are, in fact, millions and millions of people who have Alzheimer's disease biomarkers who are cognitively unimpaired, and also of their family members. So with that background, I'm going to pivot and talk a little bit about what it's like to learn that you have Alzheimer's disease biomarkers. And again, I'm focusing on people who are cognitively unimpaired as measured in the clinic. So these results are not being disclosed clinically. However, one thing that's happening is that the field is conducting many secondary prevention trials. There is a goal that we can find disease-modifying therapies, and the hope is that by intervening earlier rather than later in the course of disease, that it will be possible to slow or prevent the onset of cognitive symptoms. And so for many of these secondary prevention trials, an eligibility criterion is that individuals need to have some sort of Alzheimer's disease biomarker, and therefore, they undergo testing as they are screening for the studies. Disclosure happens to help people understand why they are or aren't eligible. And because of that disclosure process, we're able to piggyback on these studies to understand or study the effects of biomarker disclosure on cognitively unimpaired older adults. A lot of the results that I'll be sharing today are from the Socrates 1 study, the study of knowledge and reactions to amyloid testing. It's Socrates 1 because there was a Socrates 2 that looked at disclosure of genetic testing results that also spoke to Alzheimer's disease risk. But today I'm focusing on Socrates 1. We ended up interviewing 80 cognitively unimpaired adults between the ages of 65 and 85. 50 of them had what was referred to as elevated amyloid. So they underwent an amyloid PET scan and were found to have increased levels of amyloid. And 30 individuals had a not elevated amyloid result. And those individuals, because they were not eligible for the A4 study, they were shunted off into the LEARN study. We conducted 2 45-minute phone interviews, the first between a month and 3 months after the initial amyloid disclosure, and then again 12 months after that initial interview. And we transcribed and coded those interviews, and I'll be presenting those results today. One thing that's helpful to know as background is that individuals, because they were screening for A4, that clinical trial, they underwent a standardized amyloid disclosure process. This is a picture from the actual study guide that that participants received. And really the key messages around elevated amyloid were that an elevated result means that amyloid plaques are present in your brain. And an elevated amyloid result does not mean that you will experience cognitive impairment and does not mean that you will develop Alzheimer's disease dementia. Rather, this tells you that you have an increased but uncertain risk of developing cognitive impairment caused by Alzheimer's disease in the future. Now, for a long time, there had been concerns about disclosing biomarker results to cognitively unimpaired older adults. There was actually quite a bit of controversy around that practice because people had 2 overarching concerns. The first of these concerns is that it was not safe to do so, that people might react in ways that were negative or unfavorable, and also that people couldn't understand the results, particularly because they're not black and white, right? They have this nuance of increased but uncertain risk. So what we and others have found looking at biomarker disclosure is that disclosure of the results really is safe. We don't see clinically significant levels of anxiety, depression, or suicidality after people learn the results. I will offer the important caveat that this is a pre-screened population. So individuals come in, they're assessed for the trial. We did have some people anecdotally who told the investigators at our site that if they found out they had elevated amyloid, they would use that information to plan to commit suicide. So when we think about deploying this or disclosing results to a broader population, we do need to be conscientious about that. Now, the fact that it's safe to disclose should not obscure the heterogeneity of emotional responses that people have. Oftentimes when people find out they don't have elevated amyloid, they talk about relief. In fact, that's just the overwhelming emotion that they express. But people have more variable reactions when they find out they have elevated amyloid. I think unsurprisingly, there are many people who find this to be concerning. They worry about their future as a result. And then in terms of understanding, people were able to communicate back to us that they understood that This was an increased but uncertain risk of developing dementia in the future. And people who were not elevated were able to tell us that dementia has many causes, and the PET scan was one point in time, so they could always develop dementia in the future, either due to Alzheimer's disease or due to other causes of dementia. One of the things that people really did speak to us quite a bit about was that they saw these biomarker results as being different than other medical test results. And when we probed that a bit more, they came up with 4 ways in which they felt that they were different. The first one is that people really did talk about the unique implications of Alzheimer's disease biomarkers for their sense of self. So one of these people told us a colonoscopy isn't going to change who I am, but this is my brain involved. So what we see is that they not only felt like it affected their brain, but really they were talking about their mind, their sense of self-determination, their sense of who they are, and that the biomarkers threatened that in a distinct way from other test results they had received. Second, people talked about interpersonal relationships and how this would cause other people to see them differently. We had people draw comparisons to, say, losing your sight or your hearing, and how they felt that losing, as this person phrased it, your medical faculties is different. People might see you as less of a person. And I'll actually return to this idea of stigma or discrimination later in the talk today. Third, people discussed the uncertainty of the outcome, right? They knew that these results, not only might you never develop cognitive impairment, but it could be years into the future. And they really did speak to the lack of medical actionability, whereas if they had found out they had diabetes, they could take insulin. There was nothing much that they could do for this in terms of medical interventions. Now, despite recognizing the lack of medical actionability, many people did talk about learning these biomarker results as an empowering experience. And why is that? So what we saw is that people made choices around 2 main things that they felt, made it possible. This was the empowering piece. They felt like they could make changes in 2 areas. First, people talked about changing health behaviors. So people who had elevated amyloid and people who had not elevated amyloid results both talked about making some health-related changes. But the people who had elevated amyloid spoke about it very specifically in terms of trying to address their risk of Alzheimer's disease. So people were exercising more, they were sleeping more, they were engaging in brain games and trying to socialize. We had some people who were volunteering or learning new languages. And we had one person, a lot of people talked about diet and supplements that they were taking. One person spoke at some length about just how much they hate salmon. It's oily, it's disgusting, they hate it, but now they're eating it once a week because they thought that that would help their brain health. While we did see the health changes on the not elevated side, these were often in terms of a general desire for health or wellness. The other area we saw is that people use this information to inform their future plans. So people who find out they have elevated amyloid speak about changes in a variety of domains. They talk about changing financial plans. So maybe they are trying to save more money for future care expenses. In fact, oftentimes they talk about this work-leisure trade-off that's happening, where they are mindful they might need more money to care for themselves in the future, and yet they also want to have time to check things off that proverbial bucket list before they are cognitively unable to do so. People address changes in their housing situation. Sometimes it's as simple as just cleaning out your attic because you don't want your kids to have to deal with that stuff. But other people sold their house or were planning to sell their house and maybe move closer to an adult child who would be their caregiver in the future. And then we also saw some legal planning happening, or people anticipating making changes to legal documents like wills and also advance directives. People who found not elevated results talked about having a more open sense of their future. They were not making as many changes. And those changes they did make, they attributed to normal aging or things that people should do at my age rather than the amyloid result. Another area where we had some interesting findings was around the desire for medical aid in dying. So people were happy to discuss their interest in aid in dying with us. And what we saw is overall about 1 in 5 individuals indicated that they would be interested in aid in dying if they developed cognitive impairment or if they felt like they were burdening family members, right? So this isn't suicidality, this is about planfulness and thinking about a future desire for aid in dying. Now, interestingly, the people that we interviewed were oftentimes highly educated. They were relatively well off and affluent. Many had a family history of Alzheimer's disease. But they did not realize, for the most part, that they would not likely be eligible for aid in dying if they were to develop cognitive impairment. And that's because most medical aid in dying laws require that an individual both has capacity to request aid in dying and also will have a clinician who certifies they're likely to have 6 months or less to live. And this window of opportunity is unlikely to occur for individuals who have dementia caused by Alzheimer's disease, because they will not have capacity in that period where they have 6 months or less to live. Now, as I mentioned, millions of people have Alzheimer's disease biomarkers, so I think there's a chance that there will be some, growing interest in medical aid in dying and trying to change the criteria so that people who have biomarkers can be eligible in the future. Certainly, this could be a potent arm of, or a potent group of people for trying to agitate for change. And some states like Oregon have indicated they would be open to considering aid in dying for people with neurodegenerative diseases. But for those of us who are interested in legal and ethical issues, certainly we have to think about how it would be possible to allow aid in dying for this population without unwinding important protections for other people. So there will be a real balancing act that has to happen there. Now, in the absence of available aid in dying, some people did talk about doing the Thelma and Louise. So that's where, at the end of the movie, they drive their car off the cliff and commit suicide. That movie's been out long enough. I don't think that's a spoiler for anyone. But, people felt that aid in dying would be preferable to needing to commit suicide on their own without resources. And even people who said that they would never choose aid in dying for themselves due to, say, philosophical or religious reasons, often endorsed the idea that aid in dying should be available to others if they were interested in it. And interestingly, we did not see an increase in interest in aid in dying for people who had these biomarker results as, say, compared to other conditions for which aid in dying might be available. So this 1 in 5 number is actually pretty similar to, say, populations from the oncology setting. So now that we've talked a bit about the patient experience of learning biomarker results, we're going to pivot and talk about what it's like to share these results with others and how other people respond to the sharing. So in the literature, there is the disclosure decision-making model, which talks about how people make the decision to share non-visible health information with others. So things that you aren't compelled to share with others because they're evident. And this model has been used in a variety of settings to identify 3 basic steps of assessment that people go through. First, they assess the health information. So they look at the stigma that affixes to it. That's the negative attitudes that people have about people with this condition. They think about their own preparation. Were they expecting these results? And then they also look at prognosis, symptoms, and perceived relevance to others. Next, they assess the recipient. They take into account both the relational quality, how do they get along with this other person, but also what are the anticipated reactions to disclosure. And the third thing they do is they assess their disclosure efficacy. So they consider if they can share this information with this recipient and produce the desired result. And we found that this became an incredibly helpful model for thinking about how people engaged in decisions to share biomarker results with other people. In fact, everybody that we spoke with had shared the result with at least one other person. And oftentimes, these were very small numbers of people. They had been quite selective about sharing their information with others, although we had a few people who had written about it in their holiday newsletter, and even one person who had decided to speak about it on a news program in order to promote Alzheimer's disease research. So a variety of responses there. In terms of the selective sharing that happened, many people who had this not elevated result felt like it was almost no news. They did not have much concern about sharing with others. But for those who had the elevated result, it was actually quite a weighty process. People talked about the psychic energy that it took, the emotional energy, that it was much harder than they anticipated. We even had one participant who likened the sharing process to coming out of the closet. They felt that this had just been incredibly difficult for them to decide with whom, when, and how to share their results with others. So when we think about the reasons that people had for sharing with other people, this often clustered around 4 major themes. So first off, they emphasized they had a good relationship with the potential recipient of the information. Oftentimes, this was in the context of, say, a spousal relationship or a very close friendship, where people felt the norms of the relationship were that we share everything. We don't keep secrets from each other. People also talked about positive anticipated reactions, and I'll share those a bit more on the next slide. They talked about the relevance of the information to the recipient. Now, when we asked these questions about sharing, we asked them both in Socrates 1, which is the study that looked at amyloid results. We also asked them in Socrates 2, which looked at sharing of genetic information. And this concept of relevance to the recipient was much more salient in the genetic testing interviews. I think surprising nobody here, people felt that, if they had passed something on to their children, or maybe a sibling also had the same genetic, familial risk factors, that this was something that was very relevant to share, but amyloid felt less important to people. And then we saw sharing to promote the importance of research. These individuals were incredibly passionate about trying to find a disease-modifying therapy for Alzheimer's disease, and so were willing to share with others if they thought they could get those people engaged in research. So let's talk a little bit now about those positive anticipated reactions. There were 4 types of reactions that stood out to me when I looked at this information. One is that people were looking for emotional support. They oftentimes, if they had elevated amyloid, said that they knew they would need support, and they looked for people who would help them alleviate anxiety, acknowledge their sadness, sit with them with those feelings, and really make space for that emotional reaction. Now, that support piece is interesting, but there were some other findings that were more surprising to me. So one is that people were looking for monitoring. Many of them were making the decision to share with others because they were aware that they were at increased risk for cognitive impairment, and they wanted to have other people monitor them for incipient changes in their cognition that could affect their well-being. So they told their running buddies, tell me if I start repeating stories while we're out running, or tell me if I'm repeating myself or if I'm forgetting things. And, many of them felt like they might lack insight into any changes that they were experiencing. And so they had a real desire to make sure that other people were keeping them honest, right? Tell me if something is happening. They also told people to anticipate future care needs that they had. Now, one of this was more of a psychological burden or decision-making burden that they thought the other person might assume. And then the other one was more of a physical caregiving burden. So in terms of decision-making, people oftentimes already knew whom they might have or target as a surrogate decision maker, somebody who would offer them that kind of support. And so they wanted to share with people to help get them ready for assuming surrogate decision-making responsibilities, right? Get them prepared to make decisions about my future care needs and other things like that. People also knew that there were likely individuals who they would rely upon for informal caregiving support. And so they started to tell people to make sure that they knew someday they might have to take care of me. So, this, I think, reflects in part the fact that we have, as a nation, a tremendous over-reliance on informal caregivers. Again, I mentioned at the outset, 15.5 million caregivers who care for the 5.5 million people with dementia in the country. And caregiving is associated with tremendous physical, psychological, and economic burdens. So even while there are some positive aspects, it can exact a toll on people. And already at this stage, right, cognitively unimpaired, but at increased risk, people were trying to start to set up these informal caregiving networks that they felt that they might need in the future. Now, in terms of not sharing, there were certainly people who had decided that they were not going to share with people, and they had 3 particular reasons for doing this. The first one is they often highlighted that they had a poor relationship with the recipient. And I think this intuitively makes sense, right? You're not going to call up your estranged brother to tell him that you have Alzheimer's disease biomarkers, and you're not going to tell the sister-in-law that you find incredibly annoying. Those were people. We got some very unflattering pictures of other individuals in their life and of their relationships and reasons why they wouldn't be sharing. Some individuals also pointed to the lack of symptoms. So because they were cognitively unimpaired at the time of the disclosure, they felt like there was no need to tell anybody else. If I start having problems paying my bills, if I start having trouble driving, that would be the time when I would want to go ahead and tell other people. But right now, there's really nothing that can be done. There's nothing they can do. There's no urgency to share in the absence of symptoms. People pointed to that piece. And then the final part was these negative anticipated reactions. And I'm going to unpack those a bit more. So there were 3 general types of reactions. Some were just related to emotional distress, right? If I found the information distressing, it might upset her. I don't want to tell her. This person actually referred to Alzheimer's disease as this process of dwindle and decline. Many times the emotional distress was in the context of somebody who was already burdened, say by their own health issues or diagnoses, and they didn't feel like they wanted to add to that concern. And people also pointed out that there were some people who were just not emotionally ready. So I might not tell my young grandchildren that I had this. Second, people talked a lot about gossip. They worried about that friend who just can't keep their mouth shut. And if they were to share the information with that one person, it would disseminate through their network and they would not have control over the information. And so they did try to exclude those individuals from any sharing. And then we saw a tremendous amount of concern that sharing would result in stigma or discrimination, that people would feel like they needed to treat me differently as a result. So when we think of stigma, it's the negative attitudes that are associated with the condition. Unfortunately, we know that there's tremendous stigma associated with Alzheimer's disease. Some of you might be familiar with the tropes of, say, the living zombie or other things. And so, these attitudes can unfortunately prevent patients from seeking care. They can prevent caregivers from either seeking care for the person with dementia or from getting care and support for themselves. They can really be quite negative. And then discrimination is the enacted behaviors that result from the stigma. Now, people were quite concerned about this. And as we went and explored deeper what their feelings were about stigma and discrimination, they identified 4 areas where they were particularly worried. So the first one they talked about was in interpersonal relationships, right? So these are individuals, again, just to reiterate, the preclinical paradigm is that individuals have Alzheimer's disease biomarkers, but they are cognitively unimpaired when you measure them in, say, neuropsychiatric testing. But they worried that other people would not understand that. They would actually start to see and treat them differently because they wouldn't understand that they were still cognitively unimpaired. So this person says they'll assume I'm an idiot, even though I still have normal memory. And in terms of the way they saw this playing out, they felt that it might be the case that their adult children would no longer let them babysit their grandchildren, or perhaps try to take their car keys away sooner than they were ready. They still felt they were quite able to engage in all of these activities. And other people felt that it might result in, say, being excluded from their card group that they played with regularly, from lunch invitations with friends, or from various religious activities that they were affiliated with. We also saw concerns about stigma and discrimination in the workplace. And of course, we have to understand this in the broader context of stigma and discrimination experienced by older adults generally. Now, this particular quote that I have here next to "at work," where the person says it's absolutely necessary that people have confidence in my memory and decision-making, was actually a judge and felt that it was really important not to share the results because it might diminish the confidence that people had in her ability to do her job in an important way. But you didn't have to be a judge to worry that people knowing this result might mean that you would be pushed out of your job, that you might be overlooked for new opportunities that you were interested in, or that you would be asked to retire early. And certainly this is a concern for people who either felt that their workplace was still a place where they could pursue stimulation that might help them preserve their cognition and function for longer, or for people who felt that the work was very important as a means of earning money and saving money for future care expenses. So the work piece was quite complicated because not only did it have sort of a reputational harm, but it had these very instrumental effects that happened in their lives, or they worried that it would have these instrumental effects. The third place we see is in insurance purchasing. People did not talk about concerns about discrimination in health insurance. I think that had a lot to do with the fact that this was a Medicare eligible population, that people were not going to be excluded from that. But certainly because preclinical Alzheimer's disease can be diagnosed years or even decades before the onset of impairment, we have to worry about the commercial insurance market more as we think about this being disclosed more broadly. More often, people talked about life insurance and long-term care insurance, which are 2 kinds of insurance that people want when they find out that they're at increased risk for Alzheimer's disease. And they certainly worry that this would negatively affect their ability to be insured. And then the final area that I really hadn't been expecting was that people worried about discrimination in housing. This was particularly true for people who were considering moving into some sort of continuing care communities. And they worried that if there was knowledge that they had biomarkers, they would be excluded. Now, this actually does make sense when you think about it, because these continuing care communities often market themselves to people on the basis of their vibrant lifestyle. There are many activities that people can engage in. And given this context of stigma and discrimination, it's not very appealing to have people with memory problems. Memory care can also be very expensive, so there's a financial disincentive to have people move in who are at increased risk for dementia. And there are also concerns about ability to pay for people who move in and experience memory problems, given that this is a long-term housing situation. Now, while it is predominant in continuing care communities, some people were also worried about stigma and discrimination in making housing purchases in the community, or say their ability to rent an apartment. Now, unfortunately, I wish I could say otherwise, but there's probably, these concerns are probably actually very founded. And my colleague, Dr. Shana Stites, conducted a survey of a nationally representative population in which she presented vignettes of individuals who found out that they did or didn't have a biomarker. And what she found is that for the vignettes where individuals were cognitively unimpaired individuals, but they did or did not have a biomarker, that positive biomarker result resulted in significantly greater discrimination, harsher judgments about symptoms, more pity, more antipathy, and greater social distance. So people indicated that they felt that this person would be looked down upon and that others would try to remove themselves from that situation just on the basis of the biomarker result, no cognitive impairment. So what I often have to say at this point is that Alzheimer's disease is an area where we have tremendous scientific progress, right? The discovery of these biomarkers, we have a number of trials that are ongoing. We can say, not all of them have been as successful as we might have liked, but the scientific progress is astounding. But the science is really outpacing policy, and particularly legal protections for people who find out that they're at increased risk for developing dementia caused by Alzheimer's disease. Now, for genes, we have the Genetic Information Non-Discrimination Act, GINA, and while we might point to flaws or gaps in the protections afforded by GINA, the legal protections for genes are much, much better than legal protections for biomarkers, where we don't have any biomarker equivalent for GINA, right? There's no BINA. We do have numerous federal laws that might be implicated. People have explored the applicability of the Americans with Disabilities Act, right? Are these people perceived to have disabilities that might get them into some of the protections? We might look at the Federal Fair Housing Act as a hook here, but this is an area that's very murky and unsettled. I think we don't have a great sense of how those laws may or may not protect people with biomarkers. And there's also some heterogeneity from state to state. So we do see that a lot with, again, genetic protections, but the fact is that people who live just a few miles from each other, but across state lines, thanks to federalism, might have very different protections for this health information. And so when we think about disclosure, it's very important that we make sure people understand the legal context in which they're receiving this information, right? Those sources of discrimination they're worried about often will not have an answer in the law. Makes the selective sharing piece very important. Now, when people came and started talking with us at the Penn Memory Center, we saw that there were some individuals who learned a biomarker result. They shared it with a family member or a loved one. And while the participant in research actually did pretty well with the biomarker information, their loved one became almost haunted, I would say, or very anxious about the prospect of losing their loved one to Alzheimer's disease at some point in the future. And so this led to us talking about the idea of the pre-caregiver, somebody who learns they're at increased risk for informal caregiving responsibilities in the future. And we talked about some of the emotional weight that is affixed to that. And that actually led us to study family members and how they reacted to disclosure of biomarker results. And what we found is that their reactions really did parallel, to a large extent, the reactions of the older adult research participants that we had been studying in Socrates 1. So they have comparable emotional reactions, right? Relief if it's good news, but sadness if it's bad news. One thing I'd like to highlight here is the emphasis on monitoring. So people did say, we saw that some individuals wanted to be monitored for incipient changes in cognition. Here we have family members who say they're just a little bit more aware. They're watching for slips, they're watching for problems. And sometimes they wonder, is this how it begins? Now, we did not interview family members of participants in Socrates 1. So what I can't say is that there's actually a good correlation between people who want to be monitored and those who are being monitored. And I think this is an area for friction in the future where family members might not always agree on whether or not the older adult should be monitored. We also saw that family members talked about changing their own health behaviors and their future plans in light of their family members' risk. Oftentimes these were spouses who I think had such a sort of joint shared view of their future and their lives together that they made these changes in parallel with the older adult who had the elevated biomarkers. And oftentimes when they were asked to describe why they'd made the changes, they talked about the need to be well-positioned to be a caregiver in the future. So with that, I am going to turn to my last topic, which is biomarkers and supported decision-making. So when a patient receives a diagnosis of mild cognitive impairment or dementia, they're often encouraged to get their affairs in order. When we think about that, we often think about that in terms of an advance directive, right? So you update your will and you write an advance directive where you appoint a surrogate decision maker and outline your wishes for the future. Now, unfortunately, I think advance directives actually are a cautionary tale where they have some strengths. They anticipate a period of cognitive, of incapacity, right, at the end of life, typically a brief period. But for individuals who have dementia, you can have a period of, say, 8 years where individuals are not able to make decisions, and there are numerous health-related decisions that need to be made in that time. And so an advance directive is a poor fit for the needs in that cognitive trajectory. Additionally, even though rates of advanced directive completion are higher amongst people with dementia, it's often the case that about half of people don't have an advanced directive. And certainly we see disparities by race and ethnicity in terms of who has completed these documents. And so, advanced directives are not a great fit. I'm not going to say they're bad, but they're certainly not the correct answer to all of this. And so I think one of the benefits of understanding Alzheimer's disease, the continuum disorder that begins in a preclinical stage where we then progress through cognitive impairment, it really allows us to plan for a continuum of decision making. And with my colleagues, Andrew Peterson and Jason Karlowish, we've really latched onto this idea of supported decision making as a tool that can be introduced when patients have mild cognitive impairment that will help facilitate decision-making. And, there can be a progressive renegotiation of that relationship between the patient and their care partner as dementia progresses and help. So what is supported decision-making? So supported decision-making is a legally recognized tool in about half of states. Some of those states have formally adopted it. Some states are in the process of adopting it. The state where I live, Pennsylvania, unfortunately doesn't have it, but there's tremendous interest here. And a lot of stakeholders are trying to build up a supported decision-making project. And in supported decision-making, an adult who has impaired or marginal capacity, and we think of this often in terms of mild cognitive impairment, they enter freely into an agreement with a closely trusted person or persons who are referred to as supporters. And those persons assist the beneficiary in exercising and enhancing their self-determination. Now, the kinds of help people get and the domains in which they need help are part of this negotiated agreement between the beneficiary and the supporter, and it should all be beneficiary driven. So people might identify that they need help in the domain of healthcare, and they might ask for the kinds of assistance like, will you accompany me to appointments, take notes, and before it's time to make a decision, you can review pros and cons with me. Now, importantly, beneficiaries retain the right to make their own decisions and to have those decisions recognized by law. So supported decision-making has really been advocated as a less restrictive alternative to guardianship, where people's rights are taken away and given to the guardian to make decisions on their behalf. Supported decision-making should enable a longer period of people having support they need, but not having to surrender, control to others. Here's an example of Texas, which was the first state to recognize supported decision-making in the US. This is a form people can fill out on the state website. And you can see here, there's just a checklist where people can talk about the kinds of support that they might be interested in having, including physical and mental health. And there are some places you can check off to say, for example, that you will allow them to see health information, recognizing that HIPAA would otherwise be a barrier. Now, while supported decision-making shows tremendous promise, it's been used to date primarily in individuals who are transition-aged young adults with intellectual and developmental disabilities. So these are young adults who will no longer have a parent or guardian who will make decisions on their behalf. And they would prefer not to go into a guardianship immediately. And they have reported great outcomes from having supported decision-making as that less restrictive alternative. So they often report that they're happier, they have more friends, they feel more engaged in their care and their lives. But we don't know yet how older adults will feel about supported decision-making, whether it will be acceptable to them, and what factors might mediate the success of that. So I'm really excited that we are about to kick off an R01 at Penn, where we will look at supported decision-making. We have 3 aims. The first of these is to conduct a modified Delphi panel to develop a supported decision-making toolkit specific to older adults. We'll work with older adults to understand readability and characterize the determinants of intention to use that toolkit. And then in the culminating phase, the one I'm most excited about, we'll actually pilot test that in a randomized control trial at the Penn Memory Center with older adults and their care partners. So maybe in a few years, I can come back and tell you about how that project has turned out. And with that, I'll open it up to Q&A. Thank you so much.
Thank you so much, Emily. That was really wonderful. I particularly appreciated how you covered such a broad range of topics and different methods. I think that is very hard to do all in the same talk. And I know that many of our colleagues here use all those different methods. So that was really great. I also just wanted to say thank you again, of course, to our co-sponsors, the Center for Bioethics and Social Sciences as Medicine, as well as the Michigan Alzheimer's Disease Center, which I know a bunch of people are here, which is so fun. So we have a lot of questions. So I'm not even going to steal moderator's privilege and start with my own, which I usually do. So there's so many good ones. So all right, let's start with this. I'm curious to know about the decision to have the discussion about aid in dying with study participants, specifically correcting misinformation about qualifying. What types of responses occurred when they learned this information?
Yeah, so in terms of the decision to bring it up, that was not something we brought up ourselves. It turned out that, as I mentioned at the outset, Socrates had these 2 interviews, one quite close to disclosure and then one a year after the initial interview. And there were a few people who spontaneously brought up aid in dying in the first interview. And so we made a decision based on that the second interview would be modified to include questions about aid in dying. And for strategic reasons, we actually didn't address people's misperceptions within the interview. The research coordinator just kind of listened to, and we weren't quizzing them, right? We didn't ask, would you be eligible? This is something that came out when people talked about it, that they didn't understand. A few people did say, I don't live in Oregon, I don't live in a state where it's available, but many people didn't acknowledge that. And we did share the results with participants. So they subsequently, I think, saw if they chose to read that finding.
Great, thank you. Here's another, many of these questions are quite scientific in nature, so I'll start with the ones that are a little more ethical and focused on your research, but there's a lot of overlap, as you can imagine. Okay, here's another one. The major underlying factor is reliability of biomarkers. How predictive are they? What are the subjective probabilities that people attribute to positive biomarkers? And how many people interpret positive biomarkers as a certainty of AD? It's just a question of when. And I know you covered this, sort of the talk about like the actual predictability and then how predictable people see it. Could you talk to us a little bit more about those findings?
Yeah, so there's still a lot to be determined about how amyloid fits into all of this, right? What risk it actually confers to an individual to have it. We know that many people who have amyloid will never develop dementia caused by Alzheimer's disease. Oftentimes they'll die due to another cause before they have that onset of cognitive impairment. Certainly we know there are other risk factors involved. So sex, age, family history, genetics, all of these things can play in. And so I think it is quite complicated to convey it in a way that both reflects that we know it has increased risk, but also that we don't have certainty. And I know there are many people who are working on tools to try to offer a little bit more precision in predictions and, identifying who is at greater risk, even amongst people who have amyloid. I think, that's one reason why the language is kind of vague, right? It's increased but uncertain risk, trying to have a certain humility in sharing it that we don't know for sure, and emphasizing, right, that this is not a guarantee. This is one snapshot in time. We have to see what else happens. I will say, though, in reading all the transcripts, right, people really did seem to come away with that message. They understood that this was an increased risk. They didn't see it as something good or beneficial, but we really, I can only think of 1 or 2 people who misunderstood the information, and only one person who said that they, definitely now had, Alzheimer's disease and were going to be developing cognitive impairment. So people really did, I think, get the nuance. Again, we had a very educated population, and I'd be curious to see this more broadly, but I thought there was really good understanding of the information.
Yeah, because just to follow up on that, I would have thought in such a low cohort that full understanding would be lower than the vast majority of people. And so your hypothesis for that is just that it's just generally a baseline of very well educated population?
Yeah.
Because why?
I mean, the number of people in that sample who have graduate degrees is tremendous, right? It doesn't really reflect what we know. And I think the health literacy was higher, not only because of the general education, right? We know that education is an imperfect proxy for health literacy, but oftentimes these are people who are drawn into research because of a family history and strong concerns. And so I think they had very high motivation. I will say, just as like a small detour, that I've done some of the disclosure in studies and watched people take into account various risk factors. And you definitely see numeracy problems and other things as people try to understand, if it's a 10% risk here and a 15, and they try to add things up, but that's obviously not 25% when you think about how these things are related. So there's a lot to figure out still about how to communicate this, but great work, at Michigan and other places, lots of people who are thinking about how to do that well.
Great, thank you. Can you tell us the current understanding of the impact of menopause on Alzheimer's, and if there are treatments yet, such as hormone therapy? Anything in that space that you know of?
I'm going to have to say that is outside my range of
expertise,
so I will not venture there.
Okay, let's see. Oh, this is an interesting question. Are false positives and false negatives a problem? Are biomarker levels predictive of disease severity? If the test is positive, follow-up testing indicated to monitor levels? So these are obviously scientific questions, but I also think interesting in terms of your research. So did you explore false positives and false negatives and understandings of severity?
So we didn't explore that. When we talked about the elevated versus not elevated result, having a not elevated result actually didn't mean that people had no amyloid. There was a cutoff that was made. We saw that some people were fine with that. Finding out a not elevated result was like good enough for me, but there were those people who were very concerned, and they often put it in numbers that we did not use, but it's like, if I was a 9, but an elevated was a 10, I'd want to know if I was that close. So certainly there are people who are very interested in amyloid burden, as a way of contextualizing their own risk. So, again, I'm not a scientist, but my colleagues who look into this, I think, are very excited for tau imaging, as that helps. I think they feel like the patterns and the way that expands help explain deficits more. So I think that'll be an interesting area for future work, is to understand the effect of tau disclosure and how people can actually correlate symptoms they're having with the scans that they're looking at. Dan Gibbs is a neurologist out in Oregon, and he wrote a book recently about his own diagnosis with Alzheimer's disease. And he speaks, it's quite interesting to hear him reflect on his experience as both a patient and as a neurologist looking at his own scans. And I think he found the tau in some ways to be much more compelling than amyloid.
Got it. So you mentioned that this is a very highly educated population. And you also said that an interesting finding was people describing how the amyloids might be associated with a sense of self, and Alzheimer's associated with a sense of self in a way that's different than perhaps like cancer on another part of the body that doesn't affect identity in the same way. And then you also talked about the judge, right, who was particularly concerned about her decision-making being questioned. I mean, was there any sort of sub-theme where you felt like certain kinds of professional engagement was associated with particular concern?
Yeah, I mean, it's certainly a hypothesis that we have, and it's one that, given the nature of our sample, we, in our study methods, right, we didn't look into so much. But I would suspect that for people who have oftentimes defined their lives in terms of higher education and these sorts of careers, right, we had college professors, we had judges, we had, people who I think have really prized their intellectual life. that this might have a particular salience for them, that it affects their self-identity in ways others wouldn't. And certainly I think that it's complemented by findings that dementia is understood differently across, different populations. So we see, for example, by race and ethnicity, some different understandings of dementia as being normal aging or, more acceptable, whereas our group clearly found it to be quite unacceptable. So as we look at broader disclosure, I think it'll really be an important thing to look at is how do various populations understand this, because I'm not sure that finding will be consistent once we have greater heterogeneity of education, race, ethnicity, socioeconomic status. Like a number of factors I can think of might affect that finding, but all of that said, while I think that we might see some interesting variation, Alzheimer's disease is highly stigmatized and it's highly feared just because it affects self-determination and autonomy, right? People worry about it for those reasons. And so I think that we'll still see some of that, even if the emphasis is different across different populations.
Yeah, so we still have a lot of good questions, but only 5 minutes. How about another one? So you mentioned that there's no sort of amyloid protection like GINA, right? We have already codified all these protections, or maybe not all the protections that we need, but some protections under GINA, right? And you mentioned there weren't any yet. But potential avenues under ADA, what do you think should be done? Yeah, in terms of policy?
It's a fascinating area and one I really wrestle with quite a bit because, we certainly have, if we think about it just in terms of, say, insurance purchasing, right, there is a concern that if people have this information and their asymmetries, it will change the risk pool quite significantly if people are buying in. So we might think that there's actually some appropriate discrimination on the basis of risk. I've had people who are like, well, wouldn't you want to know if your doctor or your pilot or people in various positions of trust have biomarkers? And I think the answer for that is that these are cognitively unimpaired people. And so we would have to have some balance of thinking around, when might discrimination be appropriate? And additionally, what other things, I think the biomarkers alone is not enough to protect on. We need to think about it in terms of cognitive impairment as well. But ultimately, my hope is that we will have something that is GINA-like for biomarkers, just given that we have so much more information and very few protections for people who are learning in this space. And I didn't even have a chance to talk about digital biomarkers today, which I think is another area where we have a lot of information and not a lot of protections.
Great. Okay, maybe one more. In terms of like putting back on the clinical hat. So we do sometimes at Michigan, as I'm sure others do, get consults about people who maybe made a living will or made clear their what they wanted for their future self. But then when they reach their future self, particularly if it's associated with a neurodegenerative disorder or Alzheimer's, that future self wants something different than the past self wanted. However, they have since lost legal capacity. Did anybody talk about that space, or do you have any thoughts about how we should be handling that space?
I feel like this is just one of these really unresolved philosophical questions, right, about the then self and the now self. And certainly there are people who come down on both sides. We should privilege the then self, even if the person seems, say, happy now. And then there are those folks who say, well, no, we should always privilege the now self because that's the one who knows what it's like. They have epistemic access to what it's like to have dementia. And if they say they're happy or if they say they want to die, then that should be something that informs our care plans. I tend to think this is why it's so important to think about things like supported decision-making. How do we involve a care partner in this to really think about values and wishes and what is in somebody's best interest? So I think that's, I'm hoping that more communication, more open decision-making, and more deliberate involvement of care partners with the person to help support decision-making longer will help kind of get to some of those concerns. But
really helpful. Yeah, it's a hard question. Sorry.
No,
but an important one, and you certainly are well positioned to answer it. Thank you so much for coming. This was really interesting and really fun. We got a ton of people coming. Please, to all of you, this is your first Grand Rounds, please join us again. We do this once a month, and we always have great speakers. And thank you so much again to Professor Largent for joining us.
I'm delighted. Thank you so much to everyone.
Thanks, guys. Bye.